When a new patient comes to see me for a palliative care visit, sometimes I ask them, "So, what have you heard about palliative care?" And a response I commonly get is, "I Googled it, I don't really get it." Today, I'm going to explain to you exactly what a palliative care specialist does and give specific examples so that you have a better understanding of how and when a palliative care conversation could be helpful. Just as the cardiologist provides care for the patient who has heart-related disorders, so the palliative care specialist provides care for the patient who's trying to adjust with a life-altering diagnosis, trying to make the most of living with serious or complex illness, or just coming to terms with worsening illness or worsening disease. Ideally, palliative care is practiced as part of a team of experts in multiple disciplines, at least a doctor, nurse, social worker, and chaplain, because all the domains are affected when someone is trying to live with serious or complex illness. And by various domains, I mean ranging from physical symptoms like severe nausea or constipation, emotional symptoms such as anxiety, grief, or depression, trying to figure out day-to-day logistics like finding a ride to daily radiology appointments, or grappling with existential issues like loss of identity or loss of meaning. Now, some palliative care teams have these resources in multiple disciplines, whereas other palliative care teams are smaller with less resources and may consist of just one doctor or nurse practitioner or social worker, in which case this one specialist would try their best to address all the domains and refer to a specialist such as a counselor as needed. So, the following are the 6 main things that a palliative care specialist does. One, they gently communicate difficult topics that people usually tiptoe around, that are difficult to bring up even when people want to talk about them. Palliative care specialists prioritize the big picture and they ask what if questions. So in the hospital, a palliative care specialist might first gather information from all the other healthcare providers, talking to other specialists, case managers, social workers, speech therapists, physical therapists, to get their thoughts on how a patient's actually doing and their realistic expectations or thoughts on how they think a patient will do in the near future and sometimes longer term future. Then the palliative care specialist would sit down with the patient and family members, try to ascertain what they understand, clarify any misunderstandings, and then update them with the new information. They'll answer questions like, do the doctors think that I may have to come back to the hospital again and again for complications due from this treatment or due to worsening disease? Or are the doctors worried about the condition my loved one will leave the ICU? If a patient or family member really wanted to know prognosis or expected life expectancy, for example, then that will be discussed as well. In the clinic, a palliative care specialist might see a patient in between their other specialist visits, so they may not have all the information necessary to guide best medical decision making. In that case, they would encourage patients and family members to advocate for their own best care. Specifically, for example, helping with crafting pertinent questions to ask their specialist, asking about realistic potential benefit and realistic potential burdens of a proposed medical treatment, procedure, or medication. Questions such as, are the side effects of this treatment expected to sap my energy? Will I not be able to be really present for my grandchildren? Will the potential complications from this procedure or this surgery prevent me from taking care of my husband who is bedbound? Will this, if this therapy works, is it expected to give me more years or more weeks to months? Palliative care specialists guide patients and family members as they deliberate if realistic potential benefit outweigh realistic potential burden and risks as they consider different treatment paths. And they do this in the context of someone's values or what's most important to them, which leads to the second thing that palliative care specialists do. They help patients and family members articulate what's most important to them, their values, their priorities, their goals of care. I'll give an example. There are two women who are diagnosed with the same advanced cancer on the same day. One is an 80-year-old woman. She loves to garden. Her husband passed away maybe 3 years ago from lung cancer after, quote, suffering a miserable 3 months with chemotherapy, end quote. And she says, I want to have energy and be independent for as long as I possibly can. I don't want to spend the remainder of my days in and out of the hospital, in and out of the infusion centers, bedbound from side effects of chemotherapy. And when it's ready for me to join my husband, I'll be ready to go. The other woman is 60 years old, and she fervently wishes to hold her first grandbaby who's due in 7 months. So these are two women with the same diagnosis, but very different priorities and goals of care. One of them ends up canceling all of her cancer follow-up appointments, her oncology follow-up appointments, to maximize her time with family and friends at home. And the other starts cancer therapy for the goal of trying to increase her prognosis for as much as possible, whether it be weeks, months, or years. And even though these two treatment paths looked vastly different, both women were satisfied that they were receiving the best medical care possible because each set of medical care was tailored to their individual values and goals of care. So that's essentially what a palliative care specialist does. They help patients and family members articulate what's most important to them, their goals of care. They'll try to learn as much as they can about an individual patient so that they're no longer just a diagnosis and actually a person with values. They might ask questions like about what kind of work this patient did before in the home, outside the home, their family, their friends, their social life, their hobbies, their fears, their hopes, their faith, their spirituality. They might ask a patient, so what exactly is motivating you to choose this particular treatment path? What are you fighting for? What are you hoping to achieve or maintain? What at a minimum do you need to have an acceptable quality of life? After helping patients and family members articulate their goals of care, depending on the healthcare setting, palliative care specialists may then share these goals with other healthcare teams, or they'll encourage the patient and family members to share these goals with other healthcare providers. The third thing a palliative care specialist does is they clarify misconceptions about advance directives. Now, from a professional standpoint, I really only find value in two main types of advance directives or forms. One type of advance directive is any form or advance directive that asks about a patient's medical power of attorney. A medical power of attorney, or an MPOA, is also called a medical durable power of attorney, or MDPOA, or healthcare power of attorney, HCPOA, depending on the state you live in. And when I want to ask a patient about about whom they would want to name as their medical power of attorney, I ask them, if tomorrow you were delirious from a severe infection or unconscious from a bad accident or a bad stroke, whom would you trust to speak with the doctors and make all the decisions regarding your body until your mind cleared up again? Now, the other type of form is not really an advance directive. It's more of a portable doctor's order. Or in some states, they would accept a physician assistant or a nurse practitioner signature. And because there's a doctor's signature, it becomes a doctor's order. And this type of form specifically pertains to a patient's wishes for a natural death. If they were to want no CPR attempts, like the chest compression, sometimes the shocks from the electric paddles, if they would want instead a natural death, that would be a do not resuscitate. And there's a separate set of forms that would be completed with the doctor's signature to increase the chances that a person's wishes for a natural death would be honored. Now, all these types of forms could be completed by any healthcare provider, but realistically, they don't tend to be a priority topic except for palliative care specialists. Now, remember how I said earlier that palliative care is ideally practiced as part of a team? This includes working together to address uncomfortable or distressing symptoms, which often do not have just a physical cause. And addressing these uncomfortable symptoms to improve quality of life is the fourth thing that palliative care specialist focuses on. Example I'll give is, so there might be a patient who asks for a sleeping pill. They might say, oh my gosh, I have bad insomnia, I can't go to bed at night. Is there just a sleeping pill you can give me? And upon further questioning, a palliative care doctor, physician assistant, or nurse practitioner may realize that this patient's insomnia is really rooted in a lot of anxiety and racing thoughts such as, what's going to happen to my kids if something happens to me? When should I go over with my wife the passwords to our accounts and how I manage them? Will our 2-year-old remember me if I'm gone? The palliative care medical provider would realize that simply prescribing a sleeping pill may not be as effective as involving, for example, the social worker, who might also refer this patient to an attorney or an estate planner, a chaplain, a counselor, to address the physical, emotional, social, and existential domains of this patient's insomnia. This ties into the fifth thing that palliative care specialists do, which is they address the social needs as much as the physical needs. I know of a primary care physician who was once very frustrated by her patient not showing up to see the liver specialist for management of her cirrhosis, which is like liver scarring and liver failure that leads to liver failure. And she even at one point wrote non-compliant in this patient's chart. Now, this patient had insurance that covered home palliative care visits. And so when this palliative care physician and social worker showed up at this patient's home, she basically said, you know what? I do want to see the liver specialist. Health is very important to me. But I used up my bus fare paying for bread and bologna, and right now I'm just trying to figure out how to get the power turned back on. So palliative care specialists are highly reliant on the assistance of their social worker colleagues to address pressing social needs. They know that while an oncologist is describing the details of a cancer diagnosis or a nephrologist is talking about life with dialysis, the patient may be distracted thinking, how am I going to make truck payments if I can't work anymore? The palliative care specialist knows that all other aspects of a person's life, not just the medical aspect, are affected when a patient is trying to make the best of living with a serious or complex illness. And finally, the palliative care specialist supports the family as much as the patient. They know that once a patient receives a serious diagnosis, the whole family is essentially living with that serious diagnosis. A man who gets his first annual checkup for worsening vision, who finds out he has severe diabetes, well, his daughter may change her grocery shopping habits and buy butter lettuce instead of Hawaiian bread to make sloppy joes. A woman with advancing dementia who now has trouble balancing, getting into the tub, or can't remember to turn off the stove when she's cooking. Well, her grandson may decide that he's going to defer college to stay home and provide caregiving. When a palliative care specialist has a meeting involving major medical decision making in the hospital, for example, they will always involve the family members in addition to the patient, obviously with the patient's permission, and not just the patient, because they know that major medical decisions will not just affect the patient's life, but also the lives of everyone else that the patient considers family. So, in conclusion, really anyone could benefit from a palliative care conversation at any point in their health journey, whether it be when they're first diagnosed with a serious illness, when they're trying to make the most of living with a complex or serious illness, or if their health is really declining or their disease is worsening. One time, a patient asked me at our first visit, why do I really need to see you? Because wouldn't my doctor just talk about all this anyway? And I responded, it would be fantastic if your doctor did talk about all of this. And if your doctor does, you probably wouldn't benefit from any more follow-up visits with me. However, many primary care physicians, and especially specialists, don't have the training, experience, willingness, interest, time to discuss all of this. For example, the pulmonologist who focuses on lung issues probably does not spend a lot of time discussing heart and kidney issues. And so if this is the case, then a palliative care visit could be very helpful. I hope now you have a better idea of the 6 main things that a palliative care specialist does and how and when a palliative care consultation could be helpful. I hope this knowledge is helpful to you as you advocate for your best medical care. Thank you for listening. I'm Dr. Jeannie Lee with Real Palliative Care.